Yes. जोर से बोल दे भाई. I can't talk to them. One second. Yes, yes.
My question is to Dr. Gaurav. Dr. Gaurav, my question is how you stabilize the tip once you elevated it? How you stabilize the tip? Do you give any ligament sutures for that?
Yes.
He's saying, how do you stabilize the tip once you've elevated it?
Yeah.
What have you elevated?
Yeah. Once we elevate it.
But I think I'll be audible. See, you actually need to always get the ligament back. When we are closing, no, it's always advised. If we are not changing the dimensions of the tip, still we need to get the trans cartilage ligament back in position because it's helpful in the physiology also of the nose. Okay, and anyways, if you are giving a dermal suture, then anyway you are stabilizing it. Sometimes if we are getting it too much high, you put a columnar strut. So that columnar strut is fixed to the antennae spine, it's fixed to the septum posteriorly, so it becomes very sturdy and then you stabilize it.
I'm talking about this thing when you drape it back.
Okay.
When you drape it back, do you maintain the tip of it with some ligament sutures at first?
No, not at the tip area. Not at, you just, okay, I got it wrong. So we close the ligament of the medial crura area, okay, that the transdermal ligament, and then you close the tip. This thing was, I always take a subcuticular bite so that I don't want my tip to, the skin margin to go inside if you put it two sides. So you do this, your margin is little inverted and then it heals better.
So you take the skin along with the
No, a subcuticular and then the skin separately.
I am a youngster and beginner in the rhinoplasty. I have not too much experience. I have almost experience 20-25.
Even I am young youngster.
And most of the rhinoplasty I did in trauma patients. So in considering the one main problem what I encountered in starting, patient is showing I have a defect on the nose and also I have a problem in breathing, obstruction.
So it's cosmetic and functional. So there are two words in rhinoplasty, cosmetic and functional. Cosmetic is when they just want some enhancement of the aesthetics. There is no function. Function means breathing. There is no breathing issues. Function means it's breathing. Sometimes it's combined. Okay. Yes.
So the problem is I already explained in the surgical anatomy. There is almost 4 culprit things. One is the septum. We have to examine very well. Other is external wall and internal wall. The third is concha and overall structure of the nose. So septum we can see in even the CT scan, no problem. But the internal wall, external wall, I think little bit is very difficult when we are starting the rhinoplasty. So I want to search some clue and some how to examine
how to locate the site of obstruction.
What we have to correct so that aesthetical function should also correct.
Right. So whenever we are dealing with functional rhinoplasty, where there is any obstruction, better to do a CT scan done. Especially in a trauma patient. See what happens in a normal patient who just walks in, no history of any previous surgery or something. You know this anatomy, what we have studied, similar thing we'll encounter. But if trauma is happened, his nasal bone has fractured, maybe cribriform plate was fractured, it has gone down, the anterior base has gone down. And then if you go for an osteotomy, you can get connected into the anterior fossa. So always get a CT scan done. In CT scan, you will get the bony obstruction, also the septal obstruction. So that will tell you anything which is beyond your examination. So first thing is the Cottle sign. Okay. So what you do is when a patient comes complaining of obstruction, patient might tell you obstruction is on one side, maybe both sides, one side. So you press on the cheek next to your ala and pull it. And if patient says that my breathing has improved, so that means the obstruction is at the valve area. Valve area he explained. This is the external valve, the opening, and where the upper and lower lateral cartilage meet. So this point, okay. If you put a finger inside, you will feel a resistance of finger after a moment. That is the internal valve area. So Cottle sign is when you pull it. So that means you have pulled both the structure sidewards, and the valve is formed by soft tissue. So if you are pulling, your soft tissue is pulled, breathing improves. That means the problem is in the valve area. It could be a combined also. If it is at a septal area, then second thing is you use a speculum and examine where you can find any obstruction, septal deviation. Third thing is, if you have the facility, ENT have to have an endoscopy. Okay, so you can use a rigid endoscope to go inside and see for any bony obstruction. Or else you can go for a CT scan. CT scan is always good for documentation purposes also and comparing your results post-operative. So in these things, you can actually assess which level the obstruction is.
Thank you. And caudal sign and this.
Yes,
This is
yes.
very important. The caudal sign we should understand. You should read about this.
Total sign is like if you come to me just now and say, I sir, I feel obstruction, I can immediately tell you which level the obstruction is. So it is like no, nothing required.
One, I think we can also do one earbud test like that.
It's same thing.
Same.
Total sign is like more functional here, but you are pushing the cartilage here. This is like just you pull it. It's like more physiologically you are doing it.
If patient when we CT scan, we see the patient is also have a curvature in the ethmoid bone. Then sir, what we should consider?
Ethmoid bone?
Yes, I
Or
also.
bone?
Ethmoid.
See, first thing to understand it is
Because due to the trauma.
yes, correct.
Like mid-face trauma.
We don't have to correct
sometimes.
it.
Or we also just consider that this is the only septum. Then what we have to
Very good question. Now, for that we need to understand the physiology of nasal cavity. What he was not allowed because of lack of time. So physiology is only from the lower third we are breathing actually. We are not breathing from the middle and the upper third. They are for the shape only. So lower third we are breathing. Okay.
Yes.
So if there is any curvature in the ethmoid, it's not causing obstruction. We might think seeing the CT scan, ethmoid bhi block hai, ye bhi block. You have to correct only the lower third of the nasal passage for any obstructions. Okay. That is why the valve comes into play. Valve is the entry point of the lower third. Okay.
Yes.
After that, it is free flow. So you don't have to correct anything which is up then lower. Okay. Only the bases. Also, while you were giving lecture, I wanted to mention this point. Never use osteotome, especially in a post-trauma case when dealing with Homer. Okay. You always use your forceps. There are some ENT forceps which you can guide. Break it. Okay. You can use osteotome for your maxillary crest, not towards up, okay, in the midline. Because midline, if you use blindly osteotome to break the vomerine blockage, you might end up for that unwanted fracture. So vomer is very thin bone. You can always use with a forceps, ply it, it breaks and comes out. Breaks and remove, always remove in pieces. If it's not coming in one piece, take small piece, check. And how you check? Immediate post-operatively that you have got a decent opening. So you take your speculum, medium size, nasal speculums, put your speculum, not in open position, closed position. So you just put it, it slides in. Okay, if speculum slides in the nose easily, that means you have got a sufficient obstruction blockage.
In out of almost what I did, in one or two cases, when I separate the mucosa from particular septum, lower parts, and I get the peristome out.
Yes.
There is a button hole. So if it occurs, I think in beginning when you do first time, it might occur.
Yes.
It occur with me 2 times out of 20. Starting now, it's not occur, but I am not careful. It occur peristome tear the mucosa. If it tears, how to manage and what should be precautions so it should not tear.
Not tear.
Yes.
It is the most common problem. ENT surgeons are so scared. And see, my practice is more of functional rhinoplasty because I started working more with ENTs, and since my place no one is doing rhinoplasty, so they used to call me. So I deal more with functional rhinoplasties. So here thing is, if it's a deviated nasal septum, so septum is like this, okay?
Yes.
And then, can you hold the mic?
Yes.
So septum is deviated towards the right side of the patient. Now when you take a periosteal, what happens is, I told you, the technique is, like in bone what we do is, we push on the bone to expose from the periosteum. Here, you have to do fanning. You are not pushing, you are fanning. And fanning, you come to this point, immediately what happens is you go straight and you buttonhole it. So here thing is that you have to follow the septum. Okay, you have to, if you are doing fanning, you have to realize this is the maximum curvature has come, and now you have to turn it inside. If you blindly keep pushing it inside, then you will buttonhole it. When you are fanning it, you will start seeing the curvature where it's gonna turn now. Then you start following the septum. So we always ask question I ask my fellows, which side is difficult? The side with a bulge is difficult actually, because here you have a tendency to go straight and buttonhole the thing. This side you can follow the internal curvature. Okay, so the side where bulge is there, it is more difficult to raise the pericardium. Stay in the subpericardial plane. If you are in suprapericardial, more chance of buttonholing. And the problem is when you are actually damaging the pericardium or you're buttonholing it, both sides you have done it and your septum is also not in between, the patient can develop a through and through fistula. That damages the physiology of the nose. So that has to be avoided. And you can always suture it. If at all it has buttonholed, try to suture it.
2
Okay.
minutes, go ahead.
Sir,
2 minutes left. Okay.
one more questions, particularly when we, I think the nasal septum graft is one of the commonest graft used in the rhinoplasty in minor corrective surgeries, and I want to express, sir, every literature says
Okay,
one
we have
second.
got 2 minutes. I'll talk on all grafts and rhinoplasty.
Okay, sir. Just brief
So
about
all
and which
grafts.
grafts.
Okay. So one is you can harvest from the patient's septum only. Okay. So this is like same excess you harvest graft. You can use it depending on size you use it. We can't go in detail. Second option is always from your ear cartilage, the conchal grafts. Okay, but they are not straight. They don't have too much of strength. So you have to be careful use them. You can use them as only graft, but not as strengthening grafts. Okay, or you can do layer like you can use this.
Yes.
Third thing, the best graft is the rib cartilage graft. Rib cartilage, it's abundance of graft there, and you can always harvest it, shape it, make various shape, throw the remaining, keep it back, whatever you do it. But rib cartilage. So most important thing is when we are counseling the patient, I always do that. I tell them, okay, the plan is this, but I might harvest a cartilage from any other site. You should always tell them, because if you have planned, you use a conchal graft, it got damaged, it was not giving strength, then you are in a fixed position. You can't go back. So you have to always take consent that if required, it's a structural thing. If structure is weak, we are not getting the desired result, I might harvest something which is more strong. Okay.
One last question, sir. If during the exposure, sometimes a particular columnar cartilage or even the lower lateral cartilage might get a cut due to the knife.
Yes.
What is the concern about that? If get the
Concern.
small cut, what do you concern?
See,
it
if it's
to
a-
be sutured or it's let them?
If it's a through and through cut, it's a problem. You better use some cartilage graft, put it along with it and put suture to strengthen it, because it will with time might collapse. Okay, if it's a weakened cartilage. If at all it is marginal cut, you can just put a suture in there. If it's partial cut, you can always use it.
These are the common problem what I encountered. Just sir, give a very wonderful.
Amazing.
answer.
It
Thank you
was
so much,
great
sir.
working with
Thank
you.
you so much. Thank you, sir.
Thank you so
I am
much.
also in the learning phase. I think everybody is learning phase.
Everybody.
So you make a query and during the lunch and during the tea we can discuss. Any of the rhinoplasty team, I think.
Thank you.
Team won't get time. Thank you so much, guys.
Thank you.
Rahul.